Good afternoon, everybody. As somebody who spends my days looking at bugs under microscopes and politely suggesting to colleagues that perhaps not every fever needs the biggest antibiotic in an arsenal, I'm delighted to moderate this session today. This is going to be a panel discussion on the theme for the World Antimicrobial Awareness Week 2025, Act Now, Protect Our Present and Secure Our Future. We have a panel today that understands the needs for antibiotics. They understand that antibiotics work more than are essential, and they understand how important it is for antibiotics for their work. From the tiniest patients to the surgical brains, from mothers and babies to the sickest of the sick, and someone who reminds us that humans aren't the only ones fighting this battle. Welcome to this critical panel discussion for World Antimicrobial Resistance Awareness Week 2025. Yesterday, The Lancet published findings that demand our immediate attention. 83% of Indian patients undergoing routine medical procedures are carrying multi-drug resistant organisms, with nearly a quarter harboring carbapenem-resistant bacteria, organisms which are resistant to our last resort antibiotics. When more than 8 out of every 10 patients already harbor drug-resistant bacteria before reaching our hospitals, we are witnessing a public health emergency that transcends hospital walls and permeates even our communities. This brings us to a critical paradox. The solutions of AMR are simultaneously simple and complex. They're simple because we know what they need, what works: appropriate antibiotic prescribing, hand hygiene, infection prevention, and antimicrobial stewardship. Yet they are complex because implementation requires systemic change across healthcare, agriculture, environment policy, enforcement, behavioral change, and coordination across the health framework. Adding to this complexity, rapid diagnostics tools for AMR detection exist, but they remain inaccessible to those who need them the most due to the cost. The regions bearing the greatest AMR burden have the least access to these life-saving technologies, perpetuating a vicious cycle of empirical broad-spectrum antibiotics use that further enhances and accelerates resistance. This year's theme, Act Now, Protect Our Present and Secure Our Future, carries a dual urgency. For our present, every day of inaction means more lives lost. For our future, without action, we face post-antibiotic era where routine surgeries and common infections become life-threatening. The time for complacency has passed, and the moment for action is now. Thank you. I look forward to a discussion. I would like to now introduce our very knowledgeable panelists. Before that, this is the news from the study that was published in The Lancet yesterday. They coincided the publication with the start of the World Antimicrobial Awareness Week on the 18th of November. It has revealed that Indians carry 83% of the resistant bugs compared, and it's the highest globally, compared to 81% in Italy, 20% in US, 10% in Netherlands. The top sentence where it says, same disease, stark bills, which shows that if it's a gallbladder will be 70,000 for a patient who doesn't have a drug-resistant infection, and it could go up to 5 lakh for a patient, or cost his life if the patient has a superbug. I would first like to introduce Dr. Shantanu, who is a pediatrician. He's a senior consultant and HOD pediatrics with Nazareth Hospital. His key areas of expertise are infectious diseases, pulmonology, ALS, and BLS. And he has a lot of notable contributions. He's been the academic editor for IAP standard treatment guidelines and the author and writing committee member of many modules, trainer, many publications, a postgraduate teacher, and he has won the IAP Purvanchal Pioneer Award in 2013. He is affiliated to the IAP. He has been the president of East Zone, president of IAP Meghalaya currently, and national coordinator for IAP, and he has done the emergency certificate course, and he's a fellow of the IAP 2019. Next is Dr. Isaac Shira, who's an MD in general medicine. He's a consultant at Bethany Hospital. He's in charge of the ICU, a medicine consultant, and has experience of 8 years. His key areas of expertise are internal medicine, critical care, patient diagnosis, management, emergency response, ICU coordination, multidisciplinary collaboration, and clinical leadership and mentorship. I also welcome to the panel Dr. Kerlin Mihsill, a consultant obstetrician and gynecologist at Bethany Hospital and Hope Clinic, and she's also visiting consultant at Emmanuel Rural Hospital with an experience of 13 years, and her area of expertise is high risk is obstetrics, and she's affiliated to the Shillong Obstetrics and Gynecological Society and POPSI. Dr. Lamkorder, 7 years of experience. He's a neurosurgeon, consultant neurosurgeon at Bethany Hospital. His key areas of experience are brain and spine tumors, head and spine tumors, brain aneurysm, minimally invasive spine surgery, endoscopic neurosurgery. And he has a large number of notable publications, and he's affiliated to the Neurological Society of India. Dr. Kylla, who is a senior AH and veterinary officer at the State Disease Diagnostic Laboratory. And he has 18 years of experience with his key areas of interest in disease diagnosis, investigation, surveillance of livestock, and a lot of publications, and he's affiliated he's a nodal officer of the Sentinel site for surveillance of zoonosis, project investigator, ICMR surveillance, and various livestock. And that's me. I'm the moderator for the session. So I'm a consultant microbiologist. I'm the infection control lead and physician leader for the AMSP program at Bethany Hospital. I'm an NAPL NPOS assessor. My key areas of interest are, besides microbiology, antimicrobial stewardship, infection control, healthcare management. So before starting the actual question answer session, just a quick glimpse for all of you at the antibiotic sensitivity pattern, which we have calculated from our data of 4 years in Bethany Hospital. So you see more than 90%, there are really very few antibiotics. That's it, quickly. And this is just to show how scary the situation is. This is an IPD case of Klebsiella pneumoniae, resistant to almost everything. And then when we have, because we do cascade reporting, when the earlier report showed the initial antibiotics, when everything is resistant, we go to the higher antibiotics. Even there, it's equally scary. And we have a similar scenario with a lot of OPD isolates as well. So it's not just the inpatients are dying. So there's a scenario we all face, and you need an antibiotic now. So Dr. Isaac, when someone's septic and crashing in your ICU, you don't have time to wait for my culture reports. And Dr. Deb, there's a febrile patient at 2 a.m. He doesn't come with the diagnosis label. So how do you each walk the tightrope between treating aggressively and stewarding responsibly?
So we have to look at this like this. Once a patient enters the ICU, the patient is critical, as we all know. So time is not what we have at that moment. We have to be very smart in approach. We have to start, like you said, ma'am, your reports will come after 48 hours only. So we have to start some sort of broad spectrum antibiotic coverage. So to cover our bases basically. But then again, those are guidelines are there for everyone, all the clinicians. And then we have to be smart about that as well, like how do we start the empirical therapy? Maybe the patient was admitted a month back. Maybe they have some culture reports from their previous test. So that can guide us. Suppose that patient was just operated some weeks back. So accordingly, we have some sort of, we can form some idea on what type of antibiotics to give at that moment of time. Thank you.
Thank you, Dr. Judy. This is a common situation that happens to all of us, and your time of 2 a.m. does not matter. When there is a fever and you said the child is crashing, which means I will assume that there is sepsis or bacterial infection, and we will start antibiotic, but we will collect all the samples, including the samples which will be like a sepsis or septic screen for us, and all the cultures, and we will start broad spectrum antibiotic like doctor has said. But there will be many who will come with undifferentiated fever, and the mothers are worried because of the fever. They are not bothered about any infection or anything else. And if I see that there are no danger signs, like there are no signs of organ dysfunction, the child is more than 3 months old, there is no CNS infection, I would prefer to wait till at least the CRP, the procalcitonin to come, and then I'll start antibiotic. So we will take that approach because in pediatrics actually we treat both the patient and the parent. So the parents may be more worried and they may be magnifying the symptoms in the child. So we are also careful, and in such situations we will be antibiotic stewards, whereas in other situations when there is further deterioration in the health suspected, then we will be more aggressive and will treat more aggressive.
Perfect. Dr. Lam, so you have a dual expertise. I know you're practicing as a neurosurgeon now, but you have had your training done as a general surgeon as well prior to your neurosurgery practice. That's right, is it? In neurosurgery, you have a blood-brain barrier challenge with CNS penetration. But in general surgery, one has to deal with everything from appendicectomy to bowel perforations, where there are contaminated fields, polymicrobial infections. So how does the approach to antibiotics differ in these two scenarios?
Thank you, ma'am. Honestly, practicing neurosurgery and general surgery is like in two different universes. In neurosurgery, most of the cases are usually a clean case, and the infection, post-operative infection rate is usually very less, like 1 to 2%. And we used to give like a single shot of pre-operative prophylactic antibiotic, usually third generation cephalosporin. It's more than enough for a clean case. However, when the CNS infection occurs, usually the outcome becomes catastrophic. So then the blood-brain barrier came into play. Like there, we have a limited choice of antibiotics which cross the blood-brain barrier. And when CNS infection occurs, usually the treatment are very long, usually weeks or sometimes it may take months also. So the stakes are very high, and there are temptation for us like to overtreat the patient, which is not required sometimes. However, in contrast, in general surgery, most of the cases are either clean contaminated or already contaminated with a polymicrobial bacteria or already a resistant organism. So here the source control is plays a role. Once we achieve like the source control, we can think of shorten the durations of antibiotic. In most cases of like example perforated appendix, after removing the appendix, usually 3 to 5 days of antibiotic is sufficient if the source control is good and the patient is improving. So the common thread in both of this is like we should know when to stop the antibiotics. Absolutely. And we surgeons, we have that mentality just to be safe mentality, so sometimes we tend to continue for a long period of time.
So the thing is, like, if you look at the theme for this year, it is protecting our present and securing our future. We do not want to get into a situation in the future where we have absolutely nothing to treat or disease. So I think you are thinking in the right direction. Now, let's look at the One Health connection. We have with us Dr. Kylla, who's from the veterinary field. And you bring a perspective that is absolutely critical, but it is often missing from the conversations with the medical healthcare workers. We, the medical healthcare workers, we share the same antibiotics as the veterinary healthcare workers. We have the same resistance genes, the same, some of the same headaches that we come across. Can you help us in understanding when a farmer uses antibiotics in livestock, how does that eventually show up in my hospital antibiotic?
When we talk about One Health is not only about human health or animal health. It also involves a lot of criteria. It involves the human health aspect, it involves the animal health aspect, and also the important thing is environmental aspect. So all these three combine together to make a One Health responsibility for all of us. And when it comes to the veterinary department or from the animals or from the livestock aspect, so one of the important challenges we are having in veterinary department, I'm talking from my practical point of view, is like there is lots of indiscriminate use of antibiotics, particularly in the rural areas or in those who have not awareness of this antimicrobial drug resistance. So when the people started treating animals with this antibiotics, it doesn't end only in animals. It also goes to the humans who consume that meat. And when these antibiotics get into the animal's body, onto the gut of the animals, this antibiotic, they select only they kill the susceptible bacteria in the body, but they select the resistant bacteria. So this is the main problem when it comes to the antibiotic resistance. So these resistant bacteria are released into the environments. Or one of the conditions that when people are handled this poultry or poultry meat or animal meats, so there's chances of cross-contaminations when the people handle this meat. This bacteria might get into the human body also. And this is the most important things that as the public we have to be very careful when handling raw meat also. That we have to wash properly, that we have to take precautions, important aspects of hygienic is very important. So this resistant bacteria might get into the human body. That is a very dangerous thing when it gets to human body. Then that problem arises in the hospital when the doctors started treating this people who have the resistant bacteria. Then it's very difficult to treat this with the common antibiotics which we're having today. And one also is important thing is the release of this resistant bacteria into the environments. And when this bacteria are released into the environment, this resistant bacteria might get into the water sources where people utilize this water for drinking, then this resistant bacteria might get into the human body. That is one of the important criteria. I feel that the animal husbandry or the veterinary department have a lot to say in aspect of One Health aspects. So that's very important things.
Absolutely. So it's not just the human health, that the health workers or the human health industry that is responsible. There are other industries equally responsible, and we need to keep this in mind to control the issue. So, just throwing a question to the audience: how many of you have actually thought where the chicken dinner which you have at home, where do those antibiotics end up? So you need to give this a thought as well. Dr. Kerlin, have your patients ever connected this dot?
I don't think our patients really connect those dots that, what antibiotics are fed to animals are eventually ingested by us. But when we talk about that, just like Dr. Kylla mentioned, the kind of antibiotics that are given to the animals and that we ingest is finally reflects in the kind of flora that we have in our bodies. And it is a known fact that a mother's flora is passed on to a baby, even whether through the gut or whether it is through the vaginal flora. And if we do produce flora that is resistant to so many antibiotics, we are inadvertently passing that on to our baby and to the future generation eventually.
Actually, I had never had any parent raising that concern with me till now, but we get plenty of opportunities where we start a conversation. I cannot tell you the impact of ESBL producing organisms causing UTI nowadays. Almost 100% of our UTIs in pediatrics who are visiting my hospital are caused by ESBL producing organisms. And then the parents have a question, say this 10-year-old never had a course of antibiotic in its life, how come my child is affected by an organism which has so much of resistance potential? So then we bring it up that yes, the concept of One Health, it is through soil, it is through water, it is through poultry, and all these things that your child probably has got resistant organisms. And now the other thing which happens is we also need to understand that children are more affected by One Health. They are closer to the ground, they are closer to the soil, they are closer to the animal feces, they are fond of furry animals, so the contact with the children getting a resistant gene or a resistant organism is much higher probably than an adult. So that is how we start the conversation nowadays, because parents are really worried why my child is having a resistant bug when in the child's lifetime antibiotics were never used. Absolutely. So that's how we bring in the conversation.
Yeah, I just shared two of the UTI resistance antibiotic things in the beginning, so this is a very real scenario right now.
So this is what it has caused the problem in our practice. See, even innocuous UTIs, we now have to admit and give carbapenems. It is becoming like that because of ESBL producing organism. Otherwise, we know that if we don't treat it like that, the child will come back again next year, or the child will have a scarring of the kidney, which will lead to end-stage renal disease later on. So we are at the brunt of this problem that we are seeing almost every day.
And then that goes into a vicious cycle.
Yes.
Yeah. So now let's look at some reality issues. Tell me something about your worst nightmares. This is for all the clinicians here. So obstetrics has this beautiful paradox. You're protecting two lives, dealing with pregnancy physiology that changes drug handling. But cesarean sections are now amongst the most common surgeries worldwide. What's your nightmare scenario?
Yeah, yes, ma'am. So for us, for me, one of them would be a patient with puerperal sepsis or a patient who's pregnant with resistant UTI, drug-resistant UTI. Because, obviously, first of all, our antibiotic list narrows down. We know that a lot of antibiotics are passed on through the placenta to the baby and can cause teratogenicity. So we are really limited in our choice of antibiotics. And over and above that, if we have antibiotics that are already resistant, we have such a small arsenal to use. Now, thankfully, with cesarean sections, with all of our latest technology and all of that, just pre-op dose and maybe a subsequent dose after that should usually do the job, and our SSIs have really come down with that. But if you talk about a nightmare, it would be a puerperal sepsis patient for me, because that is the time when she's most vulnerable postpartum, and over and above that, she's nursing a baby. So I have to be very judicious in the choice of antibiotics, because I know that it also goes into the breast milk, and I don't want to be jeopardizing the baby as well. So those would be some of the nightmares that I'll have to probably deal with.
Okay. Dr. Lam, so you have a dual perspective because you've been trained in general surgery and you're right now a practicing neurosurgeon. So in the neurosurgical OT, you are operating in perhaps the most sterile environment imaginable. Yet when infection happens there, it's catastrophic. In the general surgery, you're often dealing with already contaminated fields, say a perforated appendix or a bowel surgery. So how does one balance the prophylaxis versus stewardship tensions across these different specialties?
The tension between, I think, neurosurgery and general surgery is different. In neurosurgery, the tension is the fear of infection, because most of the cases, as I said earlier, is clean case. But I have seen some spine surgeon, for example, a simple microdiscectomy. Okay, they have operate and give antibiotic for 1 week or more than that also, just because of the fear of infection. Usually we don't require to give that much, because by giving that long time, we will just breed resistant organisms. So my philosophy in neurosurgery is we should look at the microbiological data also. Okay, a single shot of antibiotic preoperatively, if it is a short case less than 2 hours, then it's more than sufficient. But however, if there's a CSF leak or the surgery becomes long, then we can give a second dose. And if the surgery is complicated, then we have to decide accordingly. In general surgery, the scenario is different. Most, like I already said earlier, also source control is one thing which is very important. Suppose in a perforated appendix, after removing the appendix and abdomen is washed, is clean, then we can, and patient is improving, then we can shorten the course of antibiotics.
Dr. Isaac, the ICU is the place where the antibiotics go to multiply. Okay, you have a lot of drugs, multiple drugs. You have a lot of bugs. You have multiple consultants all weighing in. You're also where I, as an infection control person, find the most spectacularly resistant organisms in my cultures. How do you manage the UN Security Council of opinions on antibiotic choices, especially when the patient is not improving?
Well put, UN Security Council. Multiple doctors, multiple consultants, multiple opinions. And us doctors, we are all very opinionated, and we all think our opinion is the best. So the thing is, sometimes, yes, it's like this. There's one case, I don't know, maybe the slide you were showing of the resistant urine, it might be our patients that me and Dr. Tyngkan are taking care of right now. He's been here in our hospital for nearly 2 months now. Came in with intracellular bleed, but he's developed complications over the time. So we needed, his kidneys started not to work well. We had to bring in a nephrologist in it. And he developed subacute intestinal obstruction. That means he wasn't passing stool properly. We had to bring in another surgeon in, 4 doctors giving their own opinion. Very difficult. But at the end of the day, thankfully, here, whatever team we have in this hospital, communication isn't a problem, I think, but there could be a communication issue in other places as well. So the thing is to communicate amongst ourselves well, the treating physicians, take each and everyone's opinions and go that way, take that route, I feel. Yeah.
Intensivist has one of the toughest jobs, I think, in the hospital, with the worst patients there and too many opinions coming in. So, Dr. Shantanu, so pediatrics is fascinating because you treat everyone from maybe a half-kilo baby to strapping teenagers who may be 70 kgs of body weight. Plus, parents are Googling everything nowadays. How do you handle the "my child need antibiotics for this cold" conversation at the age of Dr. Internet?
Currently, I have a patient who is 80 kilos also. So we see admitted yesterday, last night.
Okay.
So we see up to 18 years. Yes, it's very true. But key of pediatric practice is effective communication, and a lot of communication has to be done. So what happens is, we first emphasize after examination that this is viral illness. So we will tell them that this is a viral illness and antibiotics. If they insist, we'll tell them that antibiotics don't work in viral illnesses. Antibiotics will have a lot of side effects. It will cause diarrhea, it may cause anorexia, it may cause vomiting, it may cause rashes, it may cause tongue ulcers, oral mucosal ulcers. So all these things, we hide the negative effects of antibiotics also. But that is not enough. We need to tell them when they should return. That means we tell them the danger signs. So parents really feel empowered if we tell them that the danger signs are these, and you have to observe. For example, if your child stops being playful in between fevers, and see, now I am examining your child and I can see that your child is so much playful in spite of the fever being 103. So those things, they feel reassured. Then the next thing that we do is we also tell them that when you return, if the fever keeps on persisting, when you return, we'll do some investigations. It is too early to do investigations now because most tests, they are negative in this small window of the first 3 to 5 days. So please return after 5 days, then we'll investigate and see. And we'll tell you whether there is really any need for antibiotics. But presently or today, there is no need for antibiotics. And most of the times they listen to what we say. And how to give symptomatic relief, we teach them. Give paracetamol, give nasal drops, do hydration, put less clothes on the body, keep the room airy. So all these things, they actually help. They are more worried about the fever than about a bacterial infection. So we tell them, we empower them to deal with those issues by themselves, and they listen.
Yeah, wonderful. That's absolutely something in the right direction going on. Now, again, Dr. Lam and Dr. Isaac. Have you all ever got a call from me, from my microbiology lab, telling you all to stop post-op antibiotics? And has that made you think, what do they know about shunt infections? What do they know about intra-abdominal sepsis or about my septic patient?
Not very often, ma'am, but the thing, my first reaction if they call will be like, they are not in the OR, they don't see the pus, and they don't know how sick the patient is. But I have learned in a hard way sometimes, like they are usually right only. Because they are looking at the patient, right, at objective data. They are looking at the culture, like inflammatory markers, and fever and all. Whereas sometimes we tend to look at a patient, like this is our patient. I have operated on him or her. I have to protect him by any means. So sometimes that emotional attachment can cloud the judgment sometimes. But the call that works, I feel like when they call and say, sir, the culture is negative, the inflammatory markers are coming down, their patient has no fever for the past 48 hours, can we narrow down the antibiotic from broad spectrum to like a more targeted one? I think that's collaborative. But the call sometimes that doesn't work is like when it feels like they have a checkbox exercise. They are trying to tell you that you have exceeded the guidelines, antibiotic guideline, stop the antibiotic now. That at that point of time, I feel like they ignore the patient from the clinical point of view. Maybe that patient have an undrained pus or the surgery is complicated. So what I feel is like we need to work with each other. We need to talk as a colleague rather than adversaries.
Absolutely.
That will be beneficial to the patient.
Yeah.
Thankfully, I haven't got a call like that from them. But if I do get a call, I think that will be a reminder that there are certain parameters that I might not be thinking of. So that will keep me in a straight line, straight and narrow, they say. So, but I have disturbed Ma'am Jury once or twice before on tricky patients of pneumonia, where there was resistance to most of the antibiotic panel. Then we said, what should we do next? So she asked, yes, let us repeat the samples. Then finally we got some sort of guidance to narrow the thing. So the conversation between, I think, the lab and the doctors should go on. I think not only from that side, I think from our doctor's side also should reach out and take guidance from them as well.
Absolutely. So now let's talk about another issue which will help us secure our future, which is the real collaboration. Now here's something that fascinates me. Dr. Kerlin delivers babies who might one day be Dr. Dev's patients. Dr. Isaac's ICU patients might need Dr. Lamkoto's experience, whether it's emergency neurosurgery or maybe some other surgical abdomen. Dr. Kylla's animal surveillance data should inform what I see in the microbiology lab, yet we often work in silos. So what would real collaboration look like? Dr. Isaac, you work with almost every specialty, so what do you think is missing?
Like I said, doctors are very opinionated. We have to take sometimes a big chunk of humble pie and talk with others and communicate well. The communication as well, what we want out of this patient, what is our plans. You know, we might be wrong, but sometimes our juniors might be correct in certain aspects. So I think we should be humble enough to take opinions from each and every angle.
So, Dr. Shantanu, you're a voice for organized pediatrics nationally. You've been the vice president of the IAP. You're currently the president of the Meghalaya IAP. So how do we make stewardship everybody's problem and not just the problem of the infection control officer who's always wagging their finger and braving and pointing? And as the IAP president, what's the most common stewardship myth you're trying to bust among the pediatricians?
I will speak about the second part first. The most common myth amongst pediatricians or other clinicians also is that antibiotic stewardship means no use of antibiotic. It is not no use of antibiotics, it is rational, standardized, optimum use of antibiotics. So right dose, duration, route and everything comes into the picture. So now about our organization, Indian Academy of Pediatrics, it is a body of about 50,000 pediatricians and I can speak about them only. So what we do is in our IAP, the crux of almost the entire job of IAP is to keep on doing academic activities amongst its members. So we have lots of modules, like you had shown in my introduction slide that I am a writer of many modules. So we have a lot of modules. We have modules on all kinds of infections, and in every module we emphasize on the right antibiotic, right duration, and then finally a little bit about antibiotic stewardship. We have a module on antibiotic stewardship also, we have a module on diagnostic stewardship also, and we have a One Health module also from this year. So these modules actually reach out to the 50,000 pediatricians through the 350 branches, and we have a lot of online seminars and offline classes also. So that way actually we are trying to reach everybody so that they practice rationally. The challenges that we face or the guidance that we give them is that in OPD, how to practice antibiotic stewardship. One is think before you ink. That means take a minute to think whether this child really requires antibiotic or is it really viral or bacterial, and then you ink. The second is, the second thing that we try to make them practice is that you should always be thinking whether you are doing correct diagnostic stewardship in these patients. So use the diagnostic modalities to the optimum. Use current or recent types of diagnostic modalities. And the third thing that we say is that always write the diagnosis before you write the prescription. So that is evidence based, and it has been shown that 40% of misuse of antibiotics come down. If somebody writes viral fever, that doctor or clinician is never going to write antibiotics. So it has come down. In IPD, what we try to encourage is that you must use the correct antibiotic for the right dose, for the right duration, and always send the samples on time. So culture before starting antibiotics. So these are usually what we try to propagate. Not all pediatricians are members of IAP, and not everybody will practice it, but day by day this is improving because our leadership also has given a lot of stress on the Chennai declaration. We have also had an antibiotic stewardship declaration also from our organization in 2019. So we are heading towards an ideal world, but it is still work in progress.
Right, phenomenal work. I think we all need to take a lead from the IAP and make our associations also push them in this direction. Anything else the other panelists would like to comment on? How do we make stewardship everybody's problem?
I think today, for this panel discussion, I was just reading up in the last few days. So it dawned on me the lack of awareness by the general public. Even maybe there is a lack of awareness, even our colleagues also, you know. So from what I've heard, from what was written in the Lancet study that was done in 2019, 1.3 million deaths directly attributed to antimicrobial resistance every year. WHO says more than 1 million deaths every year for antibiotic direct. So there are other indirect also. Indirect, that means the AMR, the antimicrobial resistance, does contribute to the death. That's 4.9 million deaths a year. That's a lot. That's more than the COVID in 1 year. So we have to put our perspective in that way to spread awareness.
It's an epidemic that is silent. It's a pandemic actually that's silent.
Yes.
And
Exactly.
the awareness is not there.
Not there at all. So I'm sure Sir Shantanu also must have experience. Doctor, aren't you giving antibiotic? Let him get better faster. Then, or we get patients in our OPD. Doctor, I went and took some cold medicines and they gave me antibiotic also, and I'm not getting better after 5 days, after 3 days. But we found that that's the flu. I said.
Can I add one thing?
Yeah, sure.
We also should, advocate for curbing the over-the-counter sale of antibiotics also. That is a nuisance actually. So everybody gets some sort of antibiotic which is not at all indicated, and that also contributes to a lot of resistance also.
Absolutely. So that is also one of the policy decisions which most of the national and international governments are trying to enforce now. India is, I don't know, there have been policies, but that the enforcement is not yet there. So would you like to say anything, Dr.? Let's make this sound a little, not so sad and not so depressing. Let's look at the hope. Let's see how can we turn this around somewhere. So let's see what's working. What gives each of you optimism? So let me start with Dr. Kylla. So are there veterinary innovations that we should steal?
Yes, of course, we are talking about the indiscrimination use of antibiotics in our animal health sector. But also there's a kind of hope, since in our department we have the regular discussion seminars on antimicrobial drug resistance amongst our veterinarians. We have almost 300 veterinarians in the state, doctors in the state. and we have a regular interaction on antimicrobial resistance. And our department also has, issued several times not to use antibiotics, unnecessary antibiotics for our livestock in the farms, whether it's poultry farm, government poultry farm, or cattle farm, or pig farm. We have stopped using the antibiotics in our government farms, and we try for other means like isolation of the healthy ones from the sick one. All those biosecurity measures, we mentioned that please do hygienic measures, isolate the sick one from the healthy ones. We try to do all these things. But there's hope that since the veterans are very known about the danger of antimicrobial resistance, and our government farms, we have stopped using the growth promoters for our animals. So I hope this message will also goes to the general farmers also who need more awareness about this danger of antimicrobial drug resistance. And we have so many rapid tests nowadays for the animal disease also, which we are doing in our laboratory also. So like when the cow has mastitis, don't generally do antibiotics immediately. Go and see how severe the mastitis is by giving quick diagnosis first and see the reaction in 1 or 2 days. And also for brucellosis, I think in humans you don't have too much concern about brucellosis abortion, but the abortion in animals is a very serious case since it's a zoonotic disease can spread to humans. So brucellosis also we have a rapid diagnostic test which we can give within 5 minutes also. And so we try to encourage our veterans to adopt more traditional methods like isolations and taking care of the sick animal isolation and taking the biosecurity measures in a right way. So, and then to reduce the use of antibiotics in any sector. That's the most encouraging things for the department.
I hope all this makes a difference. Dr. Lam, any surgical advances which can reduce risk?
What makes me optimistic is like, I feel like from surgery point of view, like prevention of infection is not only we can achieve by antibiotics, even like the precise surgery or like the minimal invasive surgery can reduce the post-operative infection. For example, in neurosurgery, like now the antibiotic impregnated shunt are coming, which has reduced infection like from 6% to 2%. Normal shunt, like there's a chance of infection of around 6% after putting a shunt in a normal shunt. But with the antibiotic impregnated shunt, even it's a bit costly, but the infection rates come down to around 2%. And now the trend is like changing. Most of the surgery in neurosurgery are changing toward minimal invasive of both spine and cranial case. So yeah, the tissue damage is less, the blood loss will be less. So ultimately, infection, like post-operative infection, will also be less.
Yeah, Dr. Kerlin, anything in maternal fetal medicine?
Yeah, ma'am. So for us, simple things like if I talk to my patients about simple hygiene, you maintain hygiene, it saves you a trip to the doctor itself. Drink plenty of water. I tell a lot of my young patients, your drinking water 2 to 3 liters a day is going to save you thousands of rupees. That simple thing itself can avoid having to go through a course of antibiotics. For my pregnant patients, those who come regularly, gives me a chance as an obstetrician to understand high-risk factors, pick them up, and understand which patient will need an antibiotic average, what kind of antibiotics she will need when she goes into labor, and post that as well. So triaging these patients happens for a patient who is able to come for regular antenatal checkup. Simple hand washing techniques, and now pre-surgery, even a simple thing as taking a bath for a pre-op patient, taking a good bath, and using, just the surgical scrubbing, the way we scrub our operative site, all of that itself goes into patient's outcome post-operatively. So these are some of the things that I actually talk to my patients about, and I do tell them, that if you have any, I encourage patients, and I want to tell most of my patients, please ask questions. Ask questions. Don't hesitate to ask questions from your doctors. Today I had a patient in the OPD, unmarried girl, and she had been thrice for the same problem, for a brownish vaginal discharge, and she had been given 3 courses of antibiotics. And today I told her, I'm not going to give you anything today. Let's first investigate, see what is really happening. Come back to me because you've already got a lot of medicine. So I want patients to ask their doctors, what am I suffering from? Why are you giving me this drugs? What is this? This is an antibiotic. How am I supposed to take it? And we as doctors, we have this responsibility to tell patients, when you are on antibiotic, you must complete this course. You may feel like it's tedious, but complete it and then come back for a follow-up. So we have that kind of a stewardship as well towards them.
Dr. Shantanu, what are pediatricians doing right now?
Yes, pediatricians are doing 2 things very right. One is promoting exclusive breastfeeding, and number 2, vaccinating. These have been the biggest saviors against infection in mankind. And I see the pipeline for new antibiotics is drying up. We are not getting any new antibiotics, but more and more new vaccines will come. And these vaccines are going to save life by not causing infection. Adults should also take whatever vaccine is recommended, because as we are growing old, we are getting more comorbidities, and the risk of having a serious bacterial or a viral infection is high. So these are 2 things. I have very much faith in my fraternity, because a pediatrician is inherently very academic and inherently is a student for life. So they usually follow guidelines, and they are sort of always rational in their practice. There are a lot of studies to say that pediatricians are more rational. So I think that they will be carrying the torch forward, and the antibiotic stewardship will have good shoulders on the, they will have good results on the shoulders of pediatricians. I am hopeful.
Okay, teaching them young, catching them
Yes,
young.
yes.
So yeah, so I hope this doesn't raise any controversy. But anyways.
With no malice to any other specialty, this is what I have seen in all these years of being at the helm of affairs in a big organization also.
Yes. But then we do get to see that pediatricians nowadays actually they withhold antibiotics for a long time before deciding to start. So yeah, and Dr. Isaac, what's working in critical care, which gives you optimism?
Critical care. Now, like the first point we mentioned with you, we had to wait for 48 hours to 72 hours for culture and sensitivity tests. Now we have new modalities like what they call multiplex PCR, biofire and all those things, which we can get information what we want within 24 hours. So, but the limiting factors for those things are still the cost, very much expensive, 20,000, I think that's available in Shillong, 20 plus.
Accessibility is the problem.
Yes. Otherwise, if those things are there, rational use of antibiotic will be promoted automatically. And then obviously we can see in our hospital our infective control practices have improved a lot. So in my own personal experience, I've seen that every patient that comes to ICU, I have an overlook on all of them. So I don't see the use of last resort antibiotics as much. So that gives me hope, very much a good hope.
I think yes, the awareness is catching on, and I hope in diagnostics the prices of the machines and all the tests that are required, to give correct and quick treatment, they come down soon. Yeah.
Along with the prices, we need the insurance companies to actually support these costs.
Absolutely.
Because NHS does not support the use of these diagnostic, and that is a hindrance. Otherwise, we could have been much more streamlined in our antibiotic.
Absolutely. So it's like spending 20,000 rupees and saving maybe a couple of lakh rupees for a patient. But then that vision, like we need to create awareness for that vision right now. So the final question. So this World Antimicrobial Awareness Week, which we, because of which we are having this panel discussion today, is about spreading the message beyond this room. If you could whisper one truth about antimicrobial resistance into the ear of every patient, every family member, or every colleague, what would it be? Please make this very brief. Dr. Shantanu, yeah?
For parents, the message should be clear. Fever is not a sign of antibiotic deficiency. Antibiotics have their own side effects, so they are to be used only when they are needed. So do not unnecessarily demand antibiotics. Look for comfort and symptomatic relief of your child. To the pediatricians, again my appeal would be to empower yourself with the knowledge and be rational in practice. Know when not to use antibiotics and know when to use antibiotics judiciously. Be aware of the aware list of WHO also. Use the excess list of antibiotics, but don't go to the watch and the reserve list. For other personnel working in the hospital, hand hygiene, standard precautions, etc. Must be followed. They prevent cross-contamination and transfer of multi-drug resistant organisms from one patient to another. And to everybody in the healthcare sector, please develop the culture of sending cultures. So sending cultures actually will give you the true path to which antibiotic you can narrow down, you can de-escalate. Also use diagnostics properly like procalcitonin to de-escalate and to stop antibiotics.
Dr. La.
To all my patient, I will like to tell them, like, trust me, your surgeon good work isn't measured by how long he give you antibiotics, but how good the surgical technique is achieved and how he knows when to stop the antibiotics. And to my colleague, I would like to advise or like suggest to them, not advise, a powerful tool against fighting infection is not by giving new antibiotics, but rather try to do a meticulous job and our wisdom to know that we have done enough. Sometimes less is often more.
Yes.
Absolutely. Dr. Isaac.
Keep it short. I think antibiotics, we can tell them that it is a double-edged sword. Can save you, can kill you.
Dr. Kylla.
In this antimicrobial awareness week, I think my important message is for all is that to create more awareness about the danger of antimicrobial drug resistance. Generally for us, we are dealing with the farmers, so we have to create, this message should not be only here, or should goes to the other farmers also, that please use judiciously the antibiotics selectively and improve the hygienic conditions of the farms or the places we are there. And because bacteria don't recognize whether you are humans or animals, they may be cross resistant also between animals and humans. So spreading the message is spreading awareness to all the public and farmers is very important during this important awareness week.
Dr. Kerlin.
I would like to tell all of my pregnant patients that if you have any problem, don't just go to the pharmacist. Please come to me. Let's talk about what's happening and we can decide whether you really need an antibiotic or not, because whatever you put into your mouth, your baby gets it and thereby the future generations as well.
Absolutely. This was actually the closing round. I'd like to thank our extraordinary panel. We have a pediatrician who's been very key nationally to make policies for the national groups of pediatricians. We have a neurosurgeon who has also trained as a general surgeon prior to neurosurgery. We have an obstetrician and gynecologist. We have a physician who's also an intensivist, and we have a veterinarian here. So this diverse group, we hope, is actually the start of a solution to the problem. The bugs really don't care about our specialty boundaries, and neither should we. From Dr. Kylla's farms to Dr. Dev's nurseries, from Dr. Kerlin's delivery rooms to Dr. Lam's operating theatres, where the brain, or in case of other surgeons, the bowel, to Dr. Isaac's ICUs, and of course my microbiology lab as well. We are all in this together. If we look at the theme, act now, because antimicrobial resistance doesn't wait, it's happening while we hesitate. Protect our present, because the patients in our hospitals are already facing infections we can barely treat. This isn't a future threat, it's a current crisis. Secure our future, because every choice we make today either secures or squanders that future for the children who need these drugs in 20 years. So here's what I know from looking at culture plates. Every antibiotic we prescribe today shapes the infections we will face tomorrow. Every single one. So what does ACT now look like? It looks like Dr. Isaac waiting for culture results when he can. Dr. Deb having difficult conversations with patients. Dr. Lam navigating different decisions, sterile neurological fields with precision. Dr. Kerlin protecting 2 lives, not with panic, but with precision. Dr. Kylla reminding us that human health doesn't exist in isolation. It's all of us working, not in silos, but as a system. In my lab, I see the future arriving. New resistant, yes, but I also see antibiotic stewardship programs working. We're seeing surveillance data which is guiding better choices, and we're seeing collaborations like this panel which can catch problems early. The future isn't written yet, the bugs are evolving, and so are we. The answer depends on what each of us does tomorrow morning. So let's act now, protect our present, secure our future. From this discussion, there have been a lot of optimistic discussions as well, where most of our clinicians do see the silver lining in the clouds, and we hope that we will be able to secure a future effectively. So thank you everyone. Let's open this up to the questions from the audience.
But I just want to know whether in livestock, do you guys do cultures also like in human?
In the
In the livestock, in animals, do you really do
in the laboratory
blood cultures
diagnosis.
and all, yeah.
Yes, we almost the diagnostic what you are doing in humans health is the same in our laboratory in animal health diagnosis also. Like I am in charge of the state diagnostic laboratory where we are doing bacterial culture, fungal culture, and also ELISA, then PCR, multiplex PCR. All these systems are there. All these diagnostic systems are there in our diagnostics. That's why we have this combination of what is the most important resistance so far in the antibiotic, which is more resistant nowadays. Like when I worked 10 years back, I was working on imipenem. I got only 1 isolate out of 300 isolates. But now we have seen the cases of imipenem is like increasing up to 5 to 10%. So this is very alarming. And this is what we find out in our lab. We have that support system, diagnostic system in our animal health. It's similar to that.
resistance in them also?
Yes. So actually, bacteria which we get from animals are more resistant, I think, to this new drugs, because the use of antibiotics is more in the animal sector also. It's not only human sector, but animal sector also. Lots of antibiotics have been using. So I find that these are the good findings. Like 10 years back, you had this imipenem resistance, and now imipenem is like common drugs now. It's very resistant now.
Thank you.
Yeah, veterinary microbiology labs are actually...
What are the most commonly abused drugs in veterinary scenario, if I may ask?
That is quite controversial if I am saying now, but mostly what the general drugs used in veterinary is tetracycline, cephalexin, and now the ceftriaxone also is very commonly used. Ceftriaxone is very sensitive to most of the it's a broad spectrum antibiotic, so it's sensitive to most of gram-positive and gram-negative bacteria also. So I'll say that ceftriaxone and tetracycline, cephalexin, ciprofloxacin, these are the commonly used in veterinary sectors in our states.
Hello, sir. My name is Mavreen. So I just wanted to ask if you have any challenges that you face with regards to the surveillance of AMR in animals.
So far, we don't have the research like very extensive research, because we are just a diagnostic laboratory. We are not a research institute. So like that's why this awareness week is very important. This program which Madam hosting is very important, that we should have work together, to share the data, like from the health department, how much is resistant, which antibiotic are resistant, and from animal sector, which antibiotic are resistant. We should share this data. But so far, our main is our laboratory is as a diagnostic laboratory. So it's not, we don't go far into the sequencings of this resistant of this, what type of genes resistance and like that.
Anybody?
But when you're saying about surveillance, we whatever samples we have the data of like if you brought the meal to us, we have the data what antibiotics are working for that mastitis case, and for diarrhea cases what antibiotics are sensitive to that bacteria and which are resistant to that bacteria. We all have the data in our laboratory. Yeah.
So the data is there for future use.
It's there for future.
Dr. Shantanu.
This is again a question for you, sir. A few years back, we had learned that in poultry and livestock, only about 30% of antibiotics are being used for actually treating infections, and about 70% are being used for growth promotion. So is that true? That means in the fields they are mixed to prevent infection or for growth promotion?
Yes, like you can say like 10 years back or 15 years back, is a true case probably. But nowadays our department has stopped this use of antibiotics as a growth promoter in our government farm. Either in the poultry which you have got from government farms, or in any meals you get from we have stopped using growth promoters there in our government farms. So that message we are trying to reach to the general public, to general farmers also, that if we are showing good example or good productivity in our government farm, why the general farmers also can adopt the same principle, like main thing is following the hygienic measures and sanitations and isolation of the sick animals from the healthy animal. Those are basic steps we can take in order to avoid excessive use of antibiotics.
So as we wind up this discussion, this is just for information of our guests that we at Bethany Hospital, we have organized a 1-week World Antimicrobial Awareness Week program, and we had an inaugural session yesterday with the competition for posters, which have been created by our staff, and it's going to continue week long. There's going to be reels competition, and there's kits, and we're also doing outreach programs in colleges for awareness. So all these are things in a positive direction, and we hope the awareness catches up, and everybody, because everybody is going to be suffering the consequences, whether it's the general public or the healthcare workers, and we need to up our awareness programs and our practices. So with this, I'd like to thank all the panelists and the audience. Thank you so much. Isaac, felicitate Dr. Shantanu.